So what happens when your favorite kind of muscle, the skeletal muscle, gets hypertrophied?
So there's many ways for our favorite muscle to get hypertrophied. There's the regular way that Joe Weider described in the 1950s, the Weider method, just going out lifting heavier weights and doing progressive overload. And there's the supplemental way that which has been very popular quickly thereafter, starting in the 50s and 60s, of using anabolic steroids. What happens to the muscle is the same thing. It hypertrophies. It gets stronger. When we do exercises to increase muscle strength, we actually don't change the number of muscle fibers. We just change the thickness in the cross-sectional area.
And is that a good thing?
It's a good thing if you want to have bigger muscles or generate more power. So there's no downside to that part of it. The downsides are at the other ends of the muscles. So at either end of a skeletal muscle, which is really important for movement, posture, temporary regulation, and stabilization, there's a tendon that attaches it to the bone, which facilitates the movement because the primary function of skeletal muscle is movement. So muscles lengthen or shorten, and that's when you see a bicep pop or a hamstring pop, is when they're trying to lengthen and they're getting overworked, and the failure is usually at the musculotendinous junction or at the tendon itself. So that's the downside to getting too big and too strong. So most injuries that we see in athletes are eccentric injuries. They're the muscles trying to contract as it's lengthening. So it's being stretched and it's contracting. And those are eccentric injuries, a negative. That's like if you're in the gym and you're resisting your rep by slowly lowering a bench press. That's an eccentric exercise because the muscle is actually lengthening as you're doing it, but you're resisting it. And that's when most of these injuries, muscle tendinous injuries tend to occur. So hypertrophy is a good thing and a bad thing. Generating more strength is a great thing. It generates more power, more speed, but it does come at a risk.
We don't see a lot of massively hypertrophied athletes. Well, I don't know. I was going to say, is there a point at which it impairs athletic performance? I
think you can say it impairs athletic performance if we're talking about the injury rate. There's a much higher injury rate of tendon to bone injuries in the anabolic steroid population compared to the regular population.
Yeah.
That's where I see it, right? The people get too strong for their tendons because I don't know we haven't seen the same physiology or physiologic changes in the tendon hypertrophy as we see in the muscle hypertrophy. So the muscle hypertrophy is out of proportion to the tendon. So the tendon becomes a weak link. And that's why we see football players running on the field and tearing their Achilles tendon, making a tackle and tearing their biceps tendon.
Yes. They're too strong for the substructure.
Right. The muscle overpowers the insertion. Or the origin, whichever one you're talking about.
Or the joint.
Or the joint, correct. But yes, or the joint. But the joint's it's not as straightforward. It's more, there's rotational, there's other components to it. You rarely get pure bicep tendon avulsions from the type of stuff that happens now in people that are not using steroids.
Mm-hmm.
It's not quite so clear cut, but there's certainly an increased rate of pure tendon injuries to the people that are abusing anabolic steroids.
So, for the heart muscle, hypertrophy happens sort of in the same way. If we think about a muscle fiber in terms of principles of physics, like a spring, the afterload on a spring is simply the resistance against which it is contracting. And if you're talking about a bicep muscle, then the afterload is the weight that you're lifting. For the heart muscle, and we're particularly talking about the left ventricular chamber, the afterload against which it contracts is the blood pressure, or in some cases, the resistance at the valve above the left ventricle, the aortic valve. And so one of the main reasons why the heart muscle gets hypertrophied, gets thicker, would actually be chronic high blood pressure. And of course, that's a bad thing. And so in general, if we look at the population of people who come to see cardiologists, having markers of left ventricular hypertrophy is a risk factor that goes along with an increased risk of stroke, of heart failure, of all these bad cardiovascular complications. And over the long term, as the heart muscle gets thicker, it becomes less able to relax. And because the heart has to do this 60 or 80 times a minute, the relaxation phase for it to fill with blood is every bit as important as the contraction phase, ejecting blood out into the aorta and out into the body. And so relaxation or diastolic function, that's the lower number of the blood pressure. Blood pressure is a systolic number, 120 over 70 is the blood pressure when the ventricle is relaxing. The inability of the ventricle to relax over the long term can lead to other complications like heart failure. So in almost every instance, I'd say that hypertrophy of the heart muscle is something that we are not looking forward to. And it's really not a marker of cardiovascular fitness per se. In fact, when you go from being out of shape to being in shape, it's really not so much a remodeling of the heart muscle, although there is a bit of size and shape change of the heart. But it's really all the other parts of the cardiovascular system, the blood cells, the capillaries, the muscles, their ability to extract oxygen from the bloodstream. Those are the things that change as you get in shape. So hypertrophy of the heart muscle is probably not a good thing.
So for skeletal muscle, the hypertrophy, actually the changes are physiological and anatomic. The cross-sectional area of the muscle gets bigger. There's increased protein synthesis as it gets bigger. The satellite cells are the cells that help with repair and injury tend to proliferate. But these are most markedly observed when people undertake or use anabolic steroids. Anabolic steroids does all the same thing that resistant work does for you, but it amps it up. And the two together, resistance workouts and anabolic steroids, work in concert, and they're sort of exponential. So the other thing that we have to talk about with skeletal muscle is the energy systems. And like what happens, how do we get moving? And we talked about before fiber types. There's 3 fiber types for skeletal muscle. And each fiber type is sort of akin to an energy system. So if we're talking as a sprinter, we want to develop the CPK or the creatine phosphokinase energy system, because that gives you instant power for up to 15 seconds. So a 100-meter sprinter, a short distance swimmer, that's what they're generating. Once you get past the 10 to 15 second window, you move into the next system, which is called anaerobic glycolysis. That's another energy system that also generates ATP, ATP being the energy mitigator in the cell. ATP is what gives you energy to move. It's generated in the mitochondria, and it's what powers the movement of the muscles. So both CPK and ATP liberate, both CPK and anaerobic glycolysis lead to the production of ATP. After you run out of those 2 energy systems, you start hooking into the aerobic respiration system, which is basically your blood bringing in glucose, and the glucose gets converted to ATP. And that's way more efficient. It lasts for a much longer time, and it's what really powers us through anything over a minute to hours.
Similar to what you're describing with skeletal muscle, when the heart hypertrophies, it is enlargement of the cross-sectional area of the fibers. I can almost purely say the cells of the heart muscle do not divide and reproduce and multiply. Pretty much the heart cells that you have are the heart cells that you're gonna live with some little asterisk on that we could discuss at another date.
The skeletal muscle cells don't reproduce. but they can repair themselves, which is certainly an advantage.
So you talked a little bit about the cellular response to strength training. So let's take a hypothetical guy who is middle-aged and sedentary and has not been exercising. What happens in the weeks and months after they begin a strength training program?
Well, the first thing they're going to do is strength training is micro injuries. So when you strength train, you injure the muscles at a microscopic level, and the body repairs. And it's through reparation that the strength, to build more strength, you increase your cross-sectional area, you increase the protein synthesis, and the more you do that repeatedly, you start to see some hypertrophy. Initially, you see no hypertrophy. You see changes on the microscopic level, increased protein synthesis, quicker healing, some strengthening, some increase of capillaries, but the muscle fibers don't change. The muscle fibers change over time as the protein synthesis keeps up with the repair mechanism and starts laying down more proteins within the cells. We get hypertrophy and we get increased strength.
Now, if we take that same sedentary fellow who starts an aerobic training program, they start riding the stationary cycle or they start jogging, what we're going to see is progressive increase in that number that is often talked about, but maybe not so well understood, the VO2 max. And the VO2 max, or the maximal oxygen consumption, is really the rate at which oxygen can be delivered and consumed by the metabolizing organs, especially in the case of exercise by the muscles during physical exertion. And so it's expressed in terms of liters per minute of oxygen, and it's usually then adjusted or normalized to the body size. A little person that's obviously burning less oxygen than a bigger person. And so as the cardiovascular system becomes more efficient with training, as I said, all of the components, the blood cells, the capillaries that run through the muscles themselves and their extraction of oxygen, all of those things are going to improve their function. And so it's not really the heart itself that's so much changing. It's all of those other components that are changing as your VO2 max goes up. And as you and I have discussed, if we could pick a couple of measures of looking at a person and saying, this is somebody who's going to age well and live long, the VO2 max is a pretty incredibly powerful predictor. If you have a very high VO2 max, then you are a durable person. And similarly, I think you'd agree that if you are someone who has good skeletal muscle size and function relative to others of your age group, that is a very strong predictor of successful aging in terms of resistance to injuries and falls and frailty and all those things that we worry about as we get into our 70s, 80s, 90s, when you're like, the question is, can you get up and get out of the chair by yourself?
Right. That leads us to the whole discussion of sarcopenia, which is probably a discussion for another day, but sarcopenia is the loss of muscle fiber strength and just power as we age. So as we age, our muscles, they atrophy. They generate less power, we have less strength, and it puts us at a risk of many, many injuries and life-threatening conditions.
Yeah, and if you take a little bit more global look at the whole organism, the whole human being, the whole patient or the whole athlete, sarcopenia is an important component of the development of frailty. Frailty is really defined as the loss of the organism's ability to withstand a stress. So you are not frail because I could knock you down, or I could try, and you would bounce right back up, and you would probably not break your hip, and you would probably not go into kidney failure, and so on. But take you plus 40 years and sarcopenia, and now somebody knocks you down, and you may not get up. You are at that point frail. So sarcopenia, I agree, is a super important thing to watch out for. Now, we certainly see a lot of fellows our age now who are out there experimenting with anabolic steroids, and trying to build muscle, trying to give themselves a boost, using steroids to build muscle. What's going on there? How does that work?
Well, it does all the things resistance training does to the muscle with a whole bunch of bonuses. So it lets you lift more, lift longer, feel and recover quicker, and it increases the rate of protein synthesis. So as we discussed earlier, we build muscle by synthesizing new proteins, and they come as a result of injury and just as from stress. Stress will cause you to have increased protein synthesis and help you lay down more muscle. Anabolic steroids just ramps up that whole process. That's the good side to it. The bad side to it is it ramps up this whole process, and there's systemic effects. For the average person that we see that takes these for athletic performance, they only look at the effects of the anabolic steroids and what they're doing at that very moment. They don't look at the systemic effects. And us being physicians, and you specifically being a cardiologist, you look at the other effects of anabolic steroids, the detrimental effects, which people try to mitigate, but they're certainly there.
Yeah, for sure. There is a cardiomyopathy, which means pathy means a disease, and cardio means heart, and myo means muscle. So heart muscle disease, cardiomyopathy, meaning the heart muscle gets weaker. There is a cardiomyopathy that develops in users of high dose anabolic steroids, and that's just one of the many known and theoretical risks of anabolic steroids. Anabolic steroids have effects on the cholesterol. They have effects on glucose metabolism and insulin resistance. And the sum of all of these is very probably an increase in risk of cardiovascular events, of heart attacks, of heart failure, or stroke, and complications like that. And like any drug, that risk is probably dose related. So it does look from the clinical trials like if you take men who have abnormally low testosterone levels and you give them testosterone to get them back into the normal range, that can be done fairly safely and have some benefit in terms of physical function. The question and the problem that we both, I think, see from time to time is people who are seeing practitioners or clinics that offer this as a service, maybe with not such a strict threshold to prescribe, and maybe with treatment at a dose to achieve higher than normal levels of testosterone. And there, I think it's pretty clear that the risk of cardiovascular events would go up.
One of the other problems with testosterone is really no one knows what the appropriate level is as we age. We have ranges that are normal, but they're very broad ranges. And I can be perfectly functional with a serum testosterone of 200, and maybe at 600, I'm going to be a faster runner, but it's really not going to have any other health benefits. I just might have health risks. Or I can boost up my testosterone to a super normal level and have no benefits to my activities and just have the health risks. No one really knows what the right number is, especially as we age, because we all decrease our testosterone, but a lot of it has to do with the way we react to what testosterone we have that's actually circulating at any given time. We know people are doing it. We can see the results. It, it's your body, your risk, right?
Well, that's a real hard to answer ethical question, isn't it? Uh, for sure, we know there are people out there who are using performance enhancing drugs, and anabolic steroids seems to be the biggest and most powerful of the performance enhancing drugs. In amateur sport, I don't know. I'm not sure what they have to gain, but health risks to me would not be worth it.
In our social media driven society where everyone's picture is all everywhere, I can only see the use of anabolic steroids going up over time.
Well, I'm out there competing against myself, trying to get better, trying to slow down the process of aging without pretending that I'm going to completely reverse my inevitable aging. If I'm fortunate enough to be able to keep running masters athletics into my 70s and 80s, then I have no doubt I will be slower then than I am now. As long as you're doing better than most, I'm going to feel pretty good about myself.
I think movement is a win. I think that's the way to look at it. And it's all about movement, whether it's competing in master's track, getting on your bike, going for walks, you're doing something that you're moving and you're stressing both your cardiovascular and your skeletal muscle system. It's a win. And it's going to only do good things for you as we age.
So does exercising large muscles like doing deadlifts and squats have an impact on testosterone?
It appears that lifting large weights that are moving through using big muscle groups does help to boost testosterone, and it has a pretty big surge that lasts hours after you're finished lifting. And that is certainly one of the ways there's people that I've worked out with over the years that will go like, my bench press is improved by 20% over the last 6 months, and all I've done was squat. Like maintain the same amount of lifting I was doing before, my bench press has improved. Again, that's more than likely a testosterone effect because you're not stressing that muscle to do that, but you're certainly boosting your testosterone by lifting heavy weights through big muscle groups.
Yeah, so I don't know whether you're a data collector like I am, but I certainly have plenty of blood test results on myself going back decades. And at least in my N=1 series of self-experimentation, it does appear that when I get into a heavy lifting program and focus on squats and deadlifts and large muscle exercise, that my serum testosterone does seem to rise with that, or fall if I then drop out of that strength training program. I talked about the fear of not being able to get up out of a chair when you're 90 years old, and that really is a marker of how we would not like to end up. So squatting in particular is an exercise that has benefits for us as masters sprinters. I think even for much older folks who are simply talking about activities of daily functioning, squatting is a very important, powerful exercise. I don't like to load my spine in an axial direction so much, so I don't like to go heavy on my back and squat heavy. So I tend to look for machines that let me put some or all of the weight onto my hips, onto a belt, and squat that way. I see you're sitting in front of one such machine.
Correct. I mean, I've had back problems. I've had back injuries more than likely as a result of doing heavy squats over the years. I don't do very much squatting any longer just for those reasons. However, when I do it, I use a belt. It makes it less strenuous on your lower lumbar segments than actually having the weight on your shoulders. There's less compression involved. There still is certainly some stress in your lumbar spine, but it's less of a compressive force.
So skeletal muscle is the organ of longevity. I've heard that, and it's at least partially true, so I like it.
I like that as well. And hopefully it's it just has so many functions. I mean, no, we didn't even talk about temperature regulation. Like, what do you think controls our body temperatures when we go into a outside or we go into a hot or cold environment? There's other functions besides just biceps and triceps and, big legs. However, we are powered by this organ in our chest that we as orthopedic surgeons refer to as the ANSEF pump. ANSEF's an antibiotic we give when we operate on people. So as far as we're concerned, that muscle is there for one reason, to stop our infection rate when we're operating. However, it is the most vital of the muscles we have.
Yeah, cardiovascular fitness is really unparalleled in its ability to forestall aging and reduce your risk of dying in the long term. All right,
Agreed.
Alan, it's great to
All
see
right.
you there
Nice
in
seeing you
your
too.
in your basement weightlifting apparatus.
Perfect. And I dropped you.